for the next 1 hour, what we are going to do is, we are going to see a normal patients. So last time we did a discussion similar to this. We took very complicated case and there was a feedback like we were confusing to the core. So we will take very simple cases and see what we can learn from this in the diagnosis of diabetes, in the young patients especially. That is what we are going to do. We have Venkatakrishnan sir and Vijayakumar sir for discussion, and Anand Moses sir and PV Rao sir will be adding their inputs based on what we are doing. So everyone will be contributing. So we will, with me, Dr. Rajesh also will be joining. Rajesh, yeah.
Yes. So I'm ready with the case. So before that, a very good morning to all of you. And at the outset, let me thank Dr. G Vijayakumar sir for giving this wonderful opportunity. So I think there are two reasons why probably G Vijayakumar sir should have chosen this particular topic. One is, in the young, the characterization of diabetes is often not that very clear. It doesn't usually fit into the textbook described categories. So this is one thing. And again, establishing a proper diagnosis, what type of diabetes it is, that is very essential because it has its own therapeutic as well as prognostic implications. So with this, we have an outstanding panel here. And with them, we will explore the diagnostic dilemmas, what we usually encounter in our practice when we are looking into a case of young. So can I have the slide changer? You can do it in that laptop. So, okay. Yeah. So, let us get into the first case. Here you can see he's a 34-year-old gentleman. Sir.
Yes, sir.
Yes. So, very straightforward case. You can see a 34-year-old gentleman, teacher by profession. And before I could start, I want to thank my co-moderator, Dr. Gauri here, because he is the one who has presented all the cases. He was the one who has treated all the cases. All these cases which we are going to discuss here are all real cases. They are not simulated cases, they are real cases.
But
so
the
with
patient
this,
privacy has been protected, so
yeah.
It is all not the real patients.
Real names, real names you mean, yes. So, you have a 34-year-old gentleman, teacher by profession, and you can see in 2021 when he initially presented to somewhere else, that time his HbA1c was 12.3. At that point of time, what was the treatment given to that patient was not available. Probably he would have been treated with some insulin or with some OADs. We do not know all those things. But you can see, by this time when the patient reports to you for a follow-up, what happens is that patient is on linagliptin with metformin. At least for a year, he was on linagliptin with metformin. And now you can see from 12.3, the HbA1c has dropped down to 5.7. If you look into the morphology, he's thin built. Or you can say it is normal BMI, whatever it is. BMI is 21, and he did not have any features of insulin resistance. No acanthosis, no skin tags, no abdominal adiposity. All these features of insulin resistance was not there, were not seen in this patient. Otherwise, for discussion sake, I'm not going into the other parameters. For discussion sake, you consider that all the other metabolic parameters are normal, whether it is LFT or lipid profile or RFT. All these things are all normal. And ultrasound was done for this patient, and that was also normal. And again, he does not have no thyroid issues or no any other autoimmune disorder. Nothing is there for this patient. Can you go to the next slide?
So at this point of time, I will start the discussion with Anand Moses sir. Sir, how frequently do you see such patients in clinical care, sir? So such sort of young people, less than, when he presented, he was less than around 25, 27 years. So becoming diabetic with no signs of insulin resistance. So how frequently do we see such patients, sir?
Dr. Gauri, it's not infrequent. Nowadays, we see many patients like this, even at the age of 25 to 35, people walking into the clinic with hyperglycemia without any signs of type 1 diabetes or insulin resistance is quite common. It's very common. I think I see almost 2 or 3 cases every week where young people, from 25 to 30, incidentally diagnosed as hyperglycemia, probably when they are going for work or anything. It's not very uncommon. Probably we are seeing more now. I don't want to go into the etiology, probably we'll discuss later.
As Dr. Professor Anand also said that when we were students in medical college, and that's in the 80s actually, if anybody has got a type 2 diabetes less than 50 years, he's like a specimen for us actually. We used to go and look at them. Frankly speaking, that's hardly about 45 years ago, 45 years ago. Anybody developing diabetes less than 50 is a big issue in those days. But nowadays I think, as you say, that very common, 25, 26 also, girls going to IT jobs they're doing, very common we are seeing. But only thing is that they are all on the obese side mostly,
correct,
but not the lean.
Lean, yeah.
And why do you think that you should do ultrasonogram? That's a nice thing that you have done.
It is a part of a routine workup. We just wanted to rule out any fatty liver.
I mean, once upon a time we used to have ultrasound. When there is a thin diabetic comes, we used to do an ultrasound for pancreatic calculi. Correct. It's intrarectal pancreas, not the alcoholic pancreatitis.
What about family history?
Family history, nothing much significant was there, sir.
There's no family history.
No
of
family
that.
history of diabetes or anything in this patient. So he's from Himachal. He says like doesn't have any family history of diabetes.
Right. So, with this.
He was symptomatic at the time of diagnosis? No.
Sir, he was not symptomatic. He was not aware of the treatment that was given also. He was not treated with insulin. So, when he came for joining, this was the picture that he declared that he is a diabetic on OHS.
But the HbA1c of 12.3 and asymptomatic is very unlikely. Probably if you go to the history, many of them are symptomatic. They do not think the symptoms are significant.
But he categorically said that he was not treated with insulin any time.
No, not treated. I'm telling about symptoms.
Symptoms also he didn't say much. So
It's a job checkup.
this is when he presented, he came with a job checkup, sir.
The next important
Yes.
point is, it's a resource limited setting. We are living in a sophisticated setting. It's a rural place. There will be clues to, within 1 year, the HbA1c has come from 12.3 to 5.7. The patient has responded to a
That's what,
and metformin.
that's what
That is the next. If
Correct.
at all you don't want to work up a patient, that will be the discussion for today. With metformin and linagliptin, the patient had a response. That also gives a strong clue. If at all we are not able to do the resource limited setting, the patient is not affordable for test.
Absolutely.
That also gives a clinical clue to what is the type of diabetes.
But Gauri is working in a very highly resourceful setting.
Gauri is different, sir. Suppose the patient is in the village. So that's just we are discussing. Suppose comes from a village setup,
Yes.
not able to do. We can have a clear response to specific drugs. Also gives a clue to the type of diabetes.
So, in this context, let me ask from you, sir, Professor Venkatakrishnan, sir. So, now you have a patient, lean individual, had very high HbA1c, and again, no significant family history. Currently, this patient is on oral drugs, 2 oral drugs, and HbA1c is under control. So, this clearly rules out a type 1 diabetes. So, this could be any other type of diabetes other than type 1 diabetes. So, in this context, what could be the working diagnosis for this particular patient? In otherwise, I can frame you, what are the clues, both biochemically as well as clinically, we can get to point out any other type of diabetes apart from type 2 diabetes?
No, this 5.7 is after 2 years.
This is after 2 years with treatment with 2 oral drugs. After
1 year, okay. When you have HbA1c of 12.3 and then is a lean person, one investigation which will give a clue is the urine acetone, because he is asymptomatic. Still, a urine acetone can always say that he is insulinopenic. At that time I am telling.
Yes.
But it looks like they have put on oral drugs in 1 year, is it done well? That's a question. I think you must be having some information in the next slide, probably what has happened to the patient, then we can discuss about that.
Yeah.
So to answer Gauri's question, the first point what everybody was surprised is with the HbA1c of 12.1, the patient never had symptoms. That is also a strong clue to there's a definite, some insulin reserve is there in the body, pancreatic reserve is there in the body. that is not causing ketosis or a ketoacidosis. That is why the patient is not.
Very broadly, at this stage, it's non-type 1 diabetes.
Fantastic. Sir.
Yes. But
So, to answer, it is, we are very clear that it is not type 1 diabetes. The next thing is, any 34-year-old, the next point what we should have in mind is, there are other diabetes than type 2. So that has to be worked up. Even in a young, very young individual, it may not be type 1 diabetes. That's what is the crux of this today's discussion. Maybe Gauri will be having.
You can have surprises.
Sir,
Antibodies
That's why I
may be
said that
possible.
we'll get more information in the next slide.
sir.
It is not that we already have got a clue. When you do the next slide, we will tell that what thinking.
Sir, any other relevant investigations you want? I will ask to PV Rao, sir. So, any other investigations or any other clinical examination that this patient requires at this point of time, sir?
Most important is to treat the patient, and you already told me about the treatment part.
Sir.
Whether insulin or tablets, they have somehow managed the patient. Now his HbA1c is good. So apart from the investigations, I want to tell you about Himachal Pradesh. So I have worked, I am basically into ICMR, so I worked in Himachal Pradesh in several places. Recently we also done an India study in Himachal Pradesh, several places. As you were mentioning, diabetes was extremely rare at 4,000 meters altitude, 7,000 meters. Now it has become very common. The people are walking for 1.5 kilometers from plains to hill every day. In spite of that, they are developing diabetes. This kind of diabetes. So this is not a lean patient, he is a normal weight patient. So normal weight patient developing HbA1c of 12.3 may not be autoimmune in Himachal Pradesh. I know about the case, but I am telling you, it may not be autoimmune, but in Himachal Pradesh especially, they have found out that COPD is very common because they are all using a lot of kerosene and diesel fumes. So, in 1989, they have found out these normal weight, non-obese people at higher altitudes are down. I'm just trying to give you another direction from all the discussions. You are always focusing on antibodies, C-peptide and all that kind of thing. So there are possibilities that this person from Himachal Pradesh, earlier there were also pancreatic calculi described in Himachal Pradesh high altitudes, but now mostly it is COPD. COPD, as you know, there are a lot of deaths in diabetes attributed to air pollution from higher altitudes. So this is one. I'm just giving you another direction. So we can't do any laboratory, but anyway, routine laboratory investigations in this case in a normal weight person with diabetes, that kind of a very high 12.3 HbA1c, we just really we want to look for C-peptide, fasting or postprandial or even a casual random C-peptide is also okay, plus antibodies.
So now we will ask to Venkatakrishnan sir. Sir, Venkatakrishnan sir. Sir, do you ask any other investigation at this point of time, sir? C-peptide or autoantibody?
So any 34-year-old male, the most important thing what we look at is BMI, whether it's definitely an obese patient. And the next important thing is family history, strong family history. That will come to the next aspect. What are other types of, other than type 1, what are the, other than type 1, other than type 2, what are the other types of diabetes? We will have a clear evidence of what is the significance of family history. Apart from C-peptide, I will order for GAD65. So next, the routine screening. Based on both the fasting insulin, we will discuss. I will not order fasting insulin for all patients. In specific patients, we will order fasting insulin also. So,
No, the issue is that, you know, when we talk about the BMI, 22 is the cutoff point, right? 22 is the cutoff point for normal weight, and beyond that is overweight. Now, the Anup Mishra group have brought it down to 21.5, and there is no overweight. He says everybody is about 21.5 is obese. Now, the question is that it's not that a lean person need not be a type 2 diabetic. It still can be a type 2 diabetic, not that it cannot be. Just for the sake of working diagnosis, I am talking about that. As Dr. In fact, Dr. Venkatakrishnan and I was also speaking to Dr. Anand Moses, It's a non-type 1, but it could be most likely because it's violent, but no, it is not. He is not insulinopenic, so no acetonuria was there. Possibility of LADA. In that case, I think we need to do C-peptide and as well as GAD65. But it does not mean that every lean diabetic need to be a non-type 1 or a LADA. It can still be type 2 diabetic. Yesterday, I think if you remember that some of you have heard Dr. Sanjay Agarwal's. One of the reasons why we selected the case was that there we see in our practice both lean type 2 diabetes, overweight diabetes and obese type 2 diabetics as well. So this is one thing we need to do. One thing is that we need to discuss in the next slides that whether whom you are supposed to suspect is a non-type 2 diabetic.
Yes.
That's
See, one other similar cases we have come across when I was working in Madras Medical College, we had some good follow-up also. We had one entity which is probably not given in books as something called as a slow onset type 1 diabetes.
Yes.
Slow onset type 1 diabetes. The early stage they behave like type 2 diabetes, but still they have the antibodies positive and they keep on progressing. Maybe you can call it a type of LADA or something, but eventually they behave like type 1 diabetes after a few years.
So sir, should I interpret that we should suspect a LADA in this patient?
Yes, any young patient, I think it is now imperative you have a GAD and a C-peptide done. When it is available, it's not an expensive test now. I think
if you look into the diagnosis of LADA, the age is around 30.
30.
30
35.
to 35 is the age where we have to suspect LADA in a lean diabetic. So if it is 15 and less or something like that, most likely type 1 diabetes. If it is 45, unlikely to be LADA. But around 30 to 35 years of incidence of diabetes when are lean, when you have an HbA1c of 12.3, in spite of not having, as he said, that some amount of beta cell is reserved there, so it's not total insulinopenic, but HbA1c is there. And these are the people, age at onset is the most important, and negative family history, these are the two things will suggest us that probably it's a LADA.
So let me just ask from Professor Venkatakrishnan sir. So you have a patient like this. So you have, do you really want to do a C-peptide for this patient? Because good response with oral drugs and HbA1c is under control, which
1 year back, 2021 I have done.
That point of time, correct.
Because
Okay.
it's responded well to a gliptin and a metformin.
Sir, I will ask a question here. For the clinicians around here, can you just briefly tell what C-peptide is, what does it look like, how do we do, how to interfere?
It's a very, I'll tell it in a simple manner. It is the breakdown product of insulin. Pro-insulin. And the next important thing, what is the major difference between why we measure C-peptide, not insulin is, insulin has first pass metabolism and has a very short half-life. Here it is, the half-life of C-peptide is at least 30 to 40 minutes. And there is no first pass, significant first pass, that is metabolized by the liver. The only area where C-peptide will not be reliable is the patient should not have a kidney dysfunction. If there is a renal failure, C-peptide values may be different. You should do C-peptide in any patients to find out the functional beta cell reserve. That is the first point. Whether to do a fasting, that's what Gauri asked, or you do a post-meal. Post-meal, as per various studies, post-meal has a significant contribution to beta cell reserve than a fasting. Sometimes fasting may be misleading. Post-meal, and MMT we call it mixed meal response. I was discussing Gauri, there's a valid, he gave me a valid point that when you give Ensure Plus, so 6 scoops, it's almost equivalent to a mixed meal. You give 6 scoops and measure postprandial, Ensure Plus C-peptide will give a clear understanding of the pancreatic beta cell reserve. I think I have answered you.
Yes.
So anything that is less than 0.6, sorry, how to interpret the values, sir?
0.3, less than 0.3 fasting, sir. That is a cutoff value as per various studies. If it is less than 0.3 fasting value, you can definitely say there is no functional beta cell reserve.
Correct.
Yes. Yes. If you see, it is 80% specific.
Very good, sir.
Sensitivity almost 95%. So specific means false negative. So it rules out true, it says true positive. So then it is very clear, it is a very specific marker for beta cell reserve, first point, sensitivity. Then the next question you asked about specificity and sensitivity, I told, the next one, sir, reliability. Definitely, if you do a proper, a patient should be at least 8 to 10 hours of fasting, and tell the patient, and he has to go to the lab, not a collection center, very important. In 20 minutes we are going. Yes, he has to go to the lab, sample has to be given in the lab, which processes the sample. Not that is the collection center, they will send it there with the ice tubes or gel tubes, it is not going to work. Or specifically, if at all there is no other option, it is a rural setup, you have to have a EDTA sample. Otherwise, it is not reliable.
So can we say that, sir, if it is less than 0.3, we are ruling out type 1?
Yes. There is a subset of around 5 to 10% of patients, as with various studies, it says that fasting C-peptide may be very low. Sometimes simulated C-peptide has a good response. Those patients, we can always say that they have a reasonable beta cell reserve.
So what should be the postprandial C-peptide, sir, in that case?
3.5 at least. Exactly. 3.3 to 3.5.
So both the values have got 80% sensitivity.
Definitely.
Yes. So, yes, sir, please, sir, please, sir.
Yes, sir. If the patient is already on insulin. Yes. So that's what I told you. If C-peptide is not affected with exogenous insulin use, that is why fasting insulin is not reliable when the patient is already on insulin. So when already, yes, okay.
When do you give insulin? When there is no beta cell reserve. It's come down. So it may not be affected by that. Am I right?
Yes. So this exogenous insulin, so insulin is secreted from the beta cells. This exogenous insulin from the subcutaneous tissue, it goes to the portal circulation. So this does not affect the insulin release from the beta cells. So that is why if you are giving insulin, exogenous insulin, always be careful on sulfonylureas. A stimulation should not be given. There is high chance of hypoglycemia. The C-peptide is not affected by exogenous insulin use. The patient already on insulin, never go for a fasting insulin. You should always do a C-peptide which is never affected.
See, one more situation, when the blood sugars are very high, there is one concept called beta cell stunning. It doesn't respond. So you have a low C-peptide at that time. But when you have a good control of diabetes and repeat the C-peptide, it's always better to do a C-peptide when the glucose comes under good control, so that the real value of C-peptide.
Exactly, correct.
That is a very, very practical point that we need to take. Don't do when the patient is in glucotoxic.
When the blood sugars are very, very high, correct.
And also when the patient is in hypoglycemic state, don't do C-peptide. That is also, patient should have a near glycemia for you to check the C-peptide. Very, very practical point it is.
Right.
Sir.
It's a good question. What he asks is, type 1 diabetes, as Professor Anand Moses had told, slow development of slow progressive type 1 diabetes. So there are patients with a slow progression. If you do a simulated C-peptide for these patients, it will be low. That is very significant, even with the type 1.
Okay, sir.
Yes.
Thank you so much, sir.
But one more thing, they will not be normal levels. Even in honeymoon period, it's a lower level.
Yes.
Okay, sir.
So,
lower level of upper limit.
Normal levels. Only thing is, it is sustainable not to cause acetonuria. That's the only thing.
Okay,
The
sir.
honeymoon period can be 1 week or even a few months, not more than 1 year.
Thank you, sir.
yeah. So we have seen that we have so far we have saw that. Yeah, please add up, sir.
You also asked how to do it. So there was also a mention about collecting the sample and freezing it within 20 minutes. Your plasma has to be separated within 20 minutes. C-peptide is a stable product inside the body, but outside it is very labile fraction.
Correct.
So within 20 minutes you have to centrifuge and then separate it and put it in -20 till you And it is also, when we do for our research purposes, we also use proteolytic inhibitor called tresilol. We add tresilol in EDTA and then collect the sample and centrifuge it within 20 minutes. So doing is a very important thing. C-peptide is a very labile fraction outside the human body. That is one thing. Second thing is the variability is so much. There are so many conditions. In general, I just want to tell you that normal non-diabetics in India, have higher levels of C-peptide, both fasting and postprandial. I am talking about non-diabetics. So that levels of 0.3 or 0.6 or 0.8 or 1.5 or 3.5, what is mentioning, they may not really, it's very difficult. Each lab has to develop their own standards, their own cutoff points. For pediatric type 2 diabetes in clinical trials, what we use as a cutoff point between type 1 and type 2 is 0.8 nanograms after a meal. We are not specified which meal, what meal, how many calories, such thing. So anything that is postprandial C-peptide more than 0.8 may be type 2, maybe. We cannot say that it is type 2, but maybe type 2. If it is less than 0.8 postprandial, it is type 1. So 0.3 is an absolute cutoff point. 0.3 less than 0.3 is absolutely type 1 diabetes. So these are the criteria used in clinical trials for pediatric type 2 diabetes.
Yes, sir. One last point, one last question before going to the next slide is, sir, we have discussed so far that we are going to do a GAD antibody for this particular patient. But again, if you look into the patient profile, we see very, very commonly these kind of patients. So do we have to do GAD antibody for every patient like presenting like this, number one? And in case, if only for selected patients, if you want to do a GAD antibody, apart from for those patients, apart from GAD antibody, is it relevant to do any other antibody testing apart from GAD?
Yes. So suppose the C-peptide is normal, there is a good functional beta cell reserve. Will I do a GAD65? No.
Yes.
So we'll stop there.
Yes.
We'll assess the response. That is the most important point we should know. And other antibodies, if at all, the patient is able to afford, when you have a clear direction that this is a type 1 or not type 1, and the patient can respond to therapy, you can always wait for the antibodies. The antibodies are not going to give any clue to a therapeutic response.
Yes. So let's move on to the next.
We have only half an hour, so we can rush through.
Yeah.
Sir.
So what happened? This patient actually maintained a normal blood glucose level with oral drugs. Go to the next slide, please. Yeah.
Sir,
you showed the report of
Venkatakrishnan sir, can you just comment on this?
Very important slide. Everybody should know.
Correct.
I am making it very simple, nothing special. The first thing is whether beta cell is functioning. The second one is whether there are antibodies. That's all. It's the crux of this slide. There is nothing complicated here. Whether the patient has an antibody, plus or no. When the antibody is there, beta cell is functioning, it is LADA. Antibody is present, beta cell is not functioning, it is type 1. If there is no autoimmune antibodies, beta cell is not functioning, it is type 2. Type 2 or a family history of Modi is beta cell is functioning. Initially it mimics a type 2, less than 30 and family history of Modi. This family history will discuss, latest concepts has changed. Here this patient is very important where beta cell is not functioning, no autoantibodies. They are more prone for both diabetic ketoacidosis, microvascular and macrovascular complications.
Yes. So let's see what happened to this patient. So yeah, fasting postprandial was normal, and you can see C-peptide was done, and C-peptide response is actually very good here. You can see it is only fasting is, you can see it was 1.46, well above that 0.8 mark, and the postprandial C-peptide is 5.48. Again, it is in the normal range, which tells you that the C-peptide response is very, very good. That means the beta cell response is also very, very good. Again, when GAD65 antibody was done for this particular patient, you can see the negative value should be less than 17, but you can see the value is positive 22.03. So we have a good C-peptide response. That means insulin response is there, beta cell is responding, but the antibody is actually positive here. So what do we infer from this, sir? Antibody positive, but having a good beta cell insulin secretion is there. What do you infer? How do you now, do you change the diagnosis of this patient?
Anand Moses sir, sir, what do you say, sir? You only said like
Yes,
we have to see an antibody for this patient. Age is fitting here. beta cell reserve is good, antibodies are positive,
Probably
age fits in.
Lada here.
Okay, sir.
Eventually, probably he'll be turned out to be in future on follow-up to be a type 1 diabetes. He'll behave like a type 1 diabetes. We have seen similar cases. In fact, I have a similar patient, a person doing his MS general surgery in Tirunelveli Medical College with the same picture almost. GAD positive, but adequate C-peptide, responding well to oral antidiabetic.
How long has been responding?
He's been responding for 3 years.
Oh, that's
3 years,
good.
but yes.
Sir, can GAD antibody be false negative in this patient, sir? Is there a possibility like, are we over-diagnosing here?
The next basics about GAD.
GAD.
What is GAD? Is glutamic acid decarboxylase. It is a neurotransmitter that is synthesizes GABA. GABA is an inhibitory neurotransmitter. This GABA can be falsely positive in various neurological disorders. So, Stiffman syndrome is a very rare disease, as Anand was told. It's one of the common disorders where you get positive, false positive, and anti-GAD 65. What we say, the patient is on anti-epileptics. The history should be very clear. GAD 65 may be positive, specifically with cerebellar ataxia. Patient has other neurological disorders. You have to definitely rule out whether the patient is prone for a neurological disorder. There can be false positive. So just GAD, as I told you, GAD 65 plus GAD 65 is LADA. GAD 65 with the C-peptide normal is a rare association. So you should have totally
Sir, but it can be retrospectively only we will be seeing C-peptide becoming negative.
Yes.
But prospectively we don't see many
correct.
patients.
Yes.
So,
Correct.
as Sir was telling, the patients only we have to follow. That is what may be needed. Is that correct? My understanding,
what you are
sir?
saying is correct. Follow-up only is follow-up and therapeutic response. Clinical is the most important to decide what is the type of diabetes.
Correct. So, yes, sir, please.
I want to ask the audience and the presenters, why can't it be type 5? Recently they have been talking so much about type 5 diabetes, insulin resistant, ketosis resistant, normal body weight, common in Asian Indian population.
So the two.
Why can't it?
So the most
Why
important.
can't it be type 5?
So that will be malnourished.
This can also be some sort of undernutrition, need not be badly on some sort of MRGM, type 5.
Sir.
Of course, antibodies may not be seen in type 5, but it is plus or minus.
Exactly.
So patient systemic examination perfectly normal. There is nothing to suggest a malnutrition. So type 5 is not a.
No.
In general, sir, it's very unusual. Sir is telling the same situation, but he is responding for the last 3 years to oral drugs, which is very rare. So probably it's a false positive, the GAD antibody. Probably.
He has done the test in 2-3 places. Being a doctor, his parents are also doctors. False positive.
Sir, there is a Danish guidelines which says that if GAD antibody is positive one place, you can repeat the GAD antibody after 6 weeks in another place, and if it is so, you have to take it as positive, except when you have neurological conditions. That is the only place. Or otherwise, we can see 2-3 antibodies. If more antibodies are positive, we are moving towards antibody positive state. So, but in this patient, the other antibodies were all negative, but the GAD antibody repeated elsewhere was also positive after a period. And even 1 month back, I saw the patient, he is presenting with a similar picture, has not progressed forward, means he is still responding to OHS.
So, yes, sir.
GAD antibody alone does not predict type 1.
Correct.
You have to do other antibodies. So this GAD antibody predicts only 65 to 70% of type 1. You have to include other antibodies to rule out that he is going to develop.
Yes, sir. The point
Lab
that
study, all those studies, they have clearly shown that if you do 3 or 4 antibodies only, you will be able to eliminate.
correct, sir. But the point that we want to convey is, yes, sir.
We have much experience about GAD in general population. After Mohan, I have more data about that. So whatever Javier Salvan is saying is true. In our population, at least 18% of the general population have GAD antibodies without being diabetic, or even on follow-up, they don't turn out to be diabetic. So that's why we always encourage doing other antibodies. They are expensive, like islet cell antibody, insulin antibody. Plus, we also did a tissue transglutaminase antibody, TTG. So zinc transporter. Mohan also has done zinc transporter. So unless more than 2 pancreatic antibodies are positive, we cannot call somebody as a type 1. So GAD specific, okay, but at least 18% of the general population in India have GAD antibodies in our general population, because we have large data about that.
So it seems to be very interestingly the discussion is going on. No, almost all of us, including the practitioners who are here, you could have seen a young diabetic, maybe around 35, 40 years old and diabetic, not obese, lean, but you do a C-peptide, it is normal, but still they don't respond to tablets and we have to put insulin as well. Don't you think we are seeing such cases?
Obviously. Oh, yes, sir.
What is the reason? Do you have any answer for this?
Sir,
There are plenty of reasons we can attribute to it. Poor adherence to lifestyle, non-compliant with the diet, so many things are there. If everything...
Everything is, C-peptide is normal. They are not respond to oral drugs. We need to have a combination of oral drugs and insulin.
Yes, correct. So in this particular case, what we have seen is that you can see the autoimmunity is there, and you can see beta cell function is preserved. So probably what we are seeing is probably could be a case of LADA. We have to follow it up. In this context, let me ask from Professor Venkatakrishnan sir, this patient is already on 2 oral drugs, well under control. How are you going to follow up this patient? Are you going to depend only on the glycemic parameters alone, or we know that at some point of time the beta cell function will deteriorate, so are you going to periodically repeat a C-peptide also for this patient? From you, sir.
To the first important point, Gauri has told, never do C-peptide in glucotoxicity, and the C-peptide levels will decline over time. That is very important. Within 5 years, as per various studies, 50 to 60% of C-peptide levels will decrease over 5 years. That is the average decrease of C-peptide. Then, there is no point in repeating a C-peptide after 1 year or 2 years. So you have a clear idea. So initial C-peptide gives a clue to whether he will go for complications, whether he will respond to therapy, or whether he will require early insulin. That's what will be the clue from the initial C-peptide. Periodic follow-up C-peptide may have a role only when you have a strong doubt, and Professor Sir told, even if the value is low, you can repeat after some time with specific post-meal, MMT we call it, and we have a specific cutoff of 0.8 nanogram. Then we can have an idea that if you have a strong doubt, initial C-peptide may not be correct or falsely done, you may repeat. Otherwise, periodic
repeating is not required. So what we are going to do, we are going to monitor the glycemic parameters alone. As long as we get a good control with the oral drugs, we will be continuing that. Once we don't get a good response, that is an indication that the beta cell function has declined. So probably that is the time we have to start insulin for this patient. So with this, we will close this case.
So the carry-home points are very clear. The idea is to bring the importance of antibody and C-peptide. We bought the patient. Now we will go on to the next patient.
Previous slide, yes.
So, yeah.
Yeah.
Yes, madam. That's what I told you. We have a EDTA tube with a proteolytic enzyme incorporated. They have a tube. Various standard labs have that. So separate tube. EDTA has some effect. It can prolong to 40 minutes. But it has to reach the lab.
Within 40 minutes, it should reach the lab. That has to be complete.
That's what we discussed initially.
So we will move on to the next case. We will call her as Miss Deepa. She is a PhD student, something similar to what Mr. Bhushan presented. Almost everything is similar. So except that the previous patient was a teacher, she is a student. So at the time of admission, she is young, less than 25 years. She came with an HbA1c of about 6.9. Her fasting sugar in 2020 was about 180, postprandial 108. So there was a small discordance between the sugars and the HbA1c, because with the previous criteria, she is falling into being diabetic. When a young female presents like this, first thing that we need to think is whether anemia is contributing to it. So because in anemia, the three-dimensional configuration increases for the iron to get more affiliated. In turn, glucose also get affiliated with the three-dimensional structure of hemoglobin. So the HbA1c may increase. So her iron status has been ruled out. And the other thing which we commonly may encounter is she may have a associated hemoglobinopathy. So we did a screening for that also. Hemoglobinopathy has been ruled out. Please remember the mnemonic that we need to know is FH. So in F and H, hemoglobinopathy F and H, it may be falsely high. S, C, D all will be falsely low. FH you remember. So not all hemoglobinopathy will cause a high or low. That is something which we need to take off. So has been done. Then again in 2022 when she came, her HbA1c
No, tell us what happened to the patient at that time. Have you started on any drugs?
Nothing, no drugs.
Yes,
she
correct.
was not willing to take any drugs.
Yes.
So no medications were given. Her HbA1c was 6.9. We also may be in that age, we may be skeptical in taking any drugs. So she didn't take any drugs. Then she came with an HbA1c in 2022 with 7.3. So when she came, her fasting sugar was 143, postprandial sugar is 62. Please remember this reading. It is very important. Fasting is higher, typical like a hepatic insulin resistance. You have a hyperinsulinemic state and insulin resistance at the level of glucose also contributing to this. And with this, we wanted to know, just because the previous patient had all this suspicion, young patient, we want to do out all the antibodies. So we suspected any antibody is positive or not. So this patient was seen for 3 antibodies. All the antibodies were negative. C-peptide is normal, 2.33 fasting, and post-meal it was 5.03. So at this stage, she was started on metformin. When she was started on metformin, her HbA1c moved from 7.3 to 7.9. So after this, the patient was, because the hepatic insulin resistance was there, metformin was not responding. So we started on a low dose of sulfonylurea, and on giving low dose of sulfonylurea, her HbA1c came from 7.9 to 6.6. After that, there were some complaints issues because again the HbA1c was escalating. But please remember the point that we convey at this point is she was responding partially to a low dose of sulfonylurea.
Yes. So, with this case, let us ask from Dr. GVK sir.
Gauri, one question.
Yeah.
For the benefit of the...
Sir, that question we will take later, sir.
Later,
No, sir. Secret, sir.
Yes.
Sir, okay.
Okay.
He will anyway, sir, let him explain. Okay, we'll give what I want, the question will be answered by Gauri. So we'll also answer why there is specific postprandial hypoglycemia compared to a fast. That will be, that we should also know. The picture will be clear there and we can have a clear type of diabetes with that.
That is the most important thing that we need to know. The carry home point is that question, but we will see the discussion part.
Yeah, I can ask you the question, sir. Yes. So now you have a very young individual. You can see somewhere in the early 20s, thin-built woman, 21-year-old girl. So what you saw here was a progressive hyperglycemia. Gradually from 6.9, it went up to 7.3, and even in spite of starting metformin, it actually jumped up to 7.9. So how do you actually approach a patient like this? How do you classify the type of diabetes? Maybe will you take it as the metformin was not working, or will you take it as the sulfonylurea was working out well, or what do you infer? Progressive hyperglycemia, young individual, thin-built. Yes, sir.
I just wanted to have one question.
Yeah.
What is the family history of diabetes?
Sir, family history, her father, yes sir, family history was, her father was diabetic at the age of 46. Parents were grandparents also. She didn't give a reliable history. They say like 60 years, yeah, she was taking some medicine. Very unreliable history as far the grandparents are concerned. But father became a diabetic at the age of 46. Mother, 48 or so, she also became diabetic and she was responding to the very minimal medications.
You got an answer already. 3-generation transmission. Not responding to metformin, responding to sulfonylurea. What else?
Yes. So what we can think is that young girl presenting with hyperglycemia, could it be a type 1 diabetic because young, and you have the BMI is normal. But again, if you look into it, autoantibodies were negative. And at that point of time, no ketosis were there. So all these things were not favoring towards type 1 diabetes. Then could it be a type 2 diabetic? Again, no features of insulin resistance, no abdominal obesity, no acanthosis, no skin tags, all these features of insulin resistance was not there. And again, one thing which favors it was C-peptide response was normal. And then looking at the age of onset, could it be something else apart from type 2 diabetes? Could it be a MODY? What could be the factor, maybe probable factors which can be favoring MODY is that you can see this patient was having fasting hyperglycemia. You see, look at that fasting, without any treatment, the fasting jumped up to 146. So that is one thing. And again, the age of onset, you can see somewhere in the early part of their 20s they were presenting, and again not responding to metformin. But only once you started sulfonylurea, you had a phenomenal response to sulfonylurea. And again, as you said, the family history is also important. And do you want to say anything about the family history? How you actually elicit it? Is it really relevant in getting a diagnosis of MODY?
Family history means you nowadays what do we see, like any patient who is coming ask for a family history, they say like positive, means Indian incidence has gone up to even 20%. So we don't know like how to go about it. But one question that I will ask specifically at this point of time is, when you take a family history like this, when you take a family history like this, so these are all not alive. These are the patients who are diabetic. They all were diabetic. But here lies our patient, proband. This is our patient. So she is diabetic now. But I will ask specifically at this point of time. So they also were carrying the genes. They were also carrying the genes. But over here, none of them were getting manifested. So if a kid is born out of these parents, what will they be like, MODY or not MODY? How to account for this? And how relevant is the family history? So here it is okay. It is in our patient, it is justified. It is justified. But what will happen to this generation? So how significant is this? I'll pose this question to Anand Moses, sir.
First of all, making a diagnosis of MODY without genetic studies, I think it's not accepted in the present day. By history-wise, you can say it's probably MODY. So
we can suspect.
Your resources, have you done a genetic?
We will be showing it subsequently, sir.
It will come.
At this point of time, what we can probably think.
So the cases were not discussed with them. They are all very raw.
Correct.
So it was not discussed.
Yeah. So from the history and other thing, probably it's and response to sulfonylurea, it sounds like a MODY.
Sir, Vijayakumar, sir, how will you account for this thing, sir, family history? Are they reliable in nowadays, sir? We said 3 generation positive.
You yourself said it's not reliable. That's a grandparents' unreliable history. So unless they are tested, you can never say. Without it's only from the history. They are not testing the parents or grandparents.
You said doubtful grandparent. You said never said no to grandparent being diabetic. Probably, I mean, I still feel this is very relevant. Suppose you go to a town or a village where you don't have any resources to do anything. See, these are the things that makes more matter actually. So if you got 3 generation transmission, no ketosis, thin, and then responding only to sulfonylurea, the diagnosis is made actually. And clinical diagnosis is made. The only thing is that, see, what is it we have to try to give a message to those people who can't know resources to do the testing. And I said, for example, to do a GAD antibody or a C-peptide, there are so many restrictions that we need to do. We cannot do those things. I think this clinical picture will suffice to do that, but you want to further investigate academically, then you have to do that. And one more thing, but the moment you start sulfonylurea treatment and they do very well for years together, decades together, and if there is any doubt that the blood sugars are going up in spite of sulfonylurea, then we need to think about too many things.
Sir,
being practical.
Sir.
Genetic studies are now possible even in Chennai.
Sir,
it's not
make the for the clinicians around there, I will ask most simple question, sir. Why do you suspect MODY, and why genetic study is paramount in this patient, sir? So why means for the
academic interest.
Yes, it's Your patient is responding well to sulfonylureas. You are going to treat the patient.
As per the
But
latest,
for the labeling sake, I think you need a genetic testing, which is available in Chennai. You can, I think it costs from 10 to 15,000. You can do a Modi profiling even in Chennai.
Sir wants to add up,
No,
sir.
in fact, Dr. P.V. Rao was also suggesting that it could be type 5 diabetes. That is, once upon a time it's called as MRDM. Remember that? MRDM, that is malnutrition related diabetes. Similarly, they have found, IDF has come out with the type 5 diabetes. But the problem is they are also insulin deficient. But still he says that they can respond because the residual beta cell will be there. They may respond to.
Like your pancreatic.
I will give you another explanation. Genetic tests are done free of cost for me in Madras. I will send samples to Madras and
Yes, sir. We have done that, sir.
That's one point. Second point is actually you are trying to hide one important issue of reactive hypoglycemia. Fasting blood sugar is 140 and postprandial is about 70 or 60. So there is a
No, she didn't present symptomatic, sir.
no, not necessary, but reactive hypoglycemia postprandially is an early sign of type 2 diabetes.
But there is a steady progression of HbA1c,
I'm
sir.
just adding one point.
Okay, sir.
Reactive hypoglycemia can be a type 2 diabetes.
so as per the recent reports, Modi, with 12 to 15% of Modi does not have a family history. Does not require a family history. Not that 3 generations have to be. There can be genetic mutations without a family history. There will be specific HMF genes, transcription factor, which will be positive. Why we should do genetic study? Definitely for academic importance. And there will be specific Modis which respond to therapy. And they will not have any complications. That will be the core to discuss any genetic mutations for Modi.
Sir, again, as Dr. P.V. Rao said, here again in Chennai, if you want anybody having ruled out all the doubts, if you want to get it done free of cost, Dr. Mohan Center is doing antibodies. So
Madras Research, the Diabetes Foundation is
information.
doing
And
that.
again, the other thing very important in this, if you get a child less than 1, it's very important, they respond to sulfonylurea, there you need not start on insulin in Modi.
That is neonatal hypoglycemia.
Yeah, neonate, but still when you get under 1, you suspect Modi.
Myself and Dr. A.K. Das both are
Yeah,
in
yeah,
ICMR
அது வேற.
committee
அது வேற.
to monitor what is happening with MDR for last
Less than 1 year.
20 years.
Less than 1 year not.
But follow-up is very poor.
Complete.
Unless there is a good follow-up to really say that they are sulfonylurea sensitive or not, it is difficult to comment. That is one point. Second point is, it's not a complete genetic testing. They are doing basically hepatic nuclear factors, that's all. Potassium channels are not being done. So just because somebody has a negative genotyping doesn't mean that they are not Modi. So Modi has other genes also. They are doing about 14, 15 genes right now. But there are so
74 they are doing, sir.
74. But they are giving report for about 14 right now. But there are so many other genes, they are not yet doing potassium channel genes.
Sir. So which is not being reported. So as Sir suggested, P.V. Rao suggested, we sent a sampling to MDRF. They do free sampling. So this is the report. None of the genes tested carry any mutation. So based on the genetic analysis, the patient is not a Modi patient. So she is not a Modi. Now, why do we need to do, if at all, genetic screening for her is, these points has been already alluded, because for diagnosis, we need to certain, because the treatment for Modi is completely different. We need to know the diagnosis. For that, we need to know. Second thing is, we can screen the entire cohort of the family, so that we can know whether they also suffer by. So that is second important point. And prognosis, say if it is GCK mutation or so, there are various types. So if there is GCK mutation, only in pregnancy we need to treat. Otherwise, they won't present with any complication. That is the second most common type of Modi. So for these reasons, we need to do the genetic screening. So it is relevant for this patient to do genetic screening. So for the question that Venkatakrishnan sir asked, there is a clue in this patient that she cannot be a Modi patient because the fasting sugar was about 143, postprandial was about 60 or so. So that gives the clue that unlikely, they say only fasting hyperglycemia. They didn't say postprandial sugars will be decreased. So she is in maybe a early type 2. That is what I feel. Your comments say.
Could be. See, diabetes is a very heterogeneous disease. See, diabetes is a very, very heterogeneous disease. I think that's the reason I said that follow-up is more important. They need to follow up and then to re-diagnose. See, we should have a working diagnosis and then we may have to change it afterwards also. The follow-up is the most important. Any case that you have a diagnosis, you keep on following up, you may have to change your diagnosis later on. It is possible. But initially what it has been found is moody, but all the genes are negative, so that it can be type 2 diabetic. But the reason is that why is she not responding to metformin?
That we don't know. Really we don't know what is the reason why she is not responding to metformin. We don't know like whether they are metformin. Sir, Sanmugal sir is there.
My question is, what was the 1 hour post-glucose load value?
1 hour we didn't do, sir.
That is very important, relevant.
And TSH is
when you
normal for
when
that
you bring
patient.
2 hour value with reference to hypoglycemic range, probably that 1 hour would have resulted in very high, that can stimulate the beta cells to secrete insulin, which is relatively late, but more exaggerated. That would have resulted in hypoglycemia.
So there is a very valid carry home point that we need to carry. Sir. Sir. Yes, sir. 1 hour. Yes, sir.
So did you follow up
Sir, she is still on follow-up. She is doing extremely well with a low dose of sulfonylurea, glycoside 30 mg. She is doing very, very well. She is now 28 years old, about to get passed out, and is maintaining her HbA1c. Only problem is complaints. She feels like, why should I take drug at this age? But she is not taking metformin.
Initiating sulfonylurea, what was the 2 hour value post-meal?
Sir, post-meal was normal, sir. So that was only in 2022 she had a post-meal 60. That when she presented with the hyperinsulinemic state. After that, fasting was getting control, postprandial was getting control. She was not going into any hypoglycemia. Her quality of life is doing very well.
This is what
Please, sir.
25 years back or 30 years back we were doing. We used to call it as Mason's criteria. 3 successive generations, if the disease is there, then they respond so nicely for SU.
Sir.
So we'll kind of, we have only.
Yeah, I think we.
Next slide you can put, we can just touch upon.
I think we don't have.
Last case will take 5
We'll
minutes.
have some questions from the
Close sir.
audience and we'll wind up. That's
Yes,
Just
yes.
the last slide that Modi, you can just, we can.
So,
why genetic is important.
So,
About the Modi factors, types of Modi, you had a slide. La?
Previous slide.
Just I saw you had a slide on types of Modi.
So, one thing is, see, when we suspect Modi, this is from MDRF data. So, what we need to know is like when patients present, like though so much of patients were suspected, about 1,300 patients were suspected, so only 45 of them were turning out positive. So, it makes a difference when you suspect for that one patient when a genetic study is positive. So, please write to MDRF for a free testing. They are very happy to offer. I have done for many patients. So, this is their data. So, it makes a difference for that 1 in 30 patient.
Better to have first 3 Modi. And Modi 2 has the good prognosis with late complications, less complications. As Madam told, Modi 10 is neonatal diabetes.
No, the issue is that the suspicion in more than 1,000, only 45 are positive.
Yes, sir. This is
That's the most important thing.
This is their
So I think this is a very important point they have brought in. So out of about more than 1,000 patients screened, only 45 positive. And then if you can see that if you see such a situation, there is always a possibility of a type 2 diabetes as well. But only thing is, the only query which we cannot answer is that why they are not responding to metformin, responding only to sulfonylurea is the most important question. But nevertheless, it is, we need to bring down the blood glucose, whatever, whether he is responding to metformin or sulfonylurea, it's okay. It doesn't matter.
And follow up the case meticulously. And she is on, after all these things, she is on follow up for 3 years. She is doing well.
We'll have a few questions, 1 or 2 questions,
Yes.
and we'll wind up.
Yes.
Sir, Baimark.
It's a simple common question, sir. Actually, Modi will not respond to metformin because it is the mechanism actually is different.
She is not Modi, sir.
Generally.
Sir. Okay, sir. Okay.
Generally, it will not respond to metformin. Yes, sir.
But Modi, what they said is, why it's in Modi respond to sulfonylurea? That is the question. Why does it respond? Because the beta cell secreting insulin. Now, why it is not secreting insulin normally? Why it is sulfonylurea is making it to secrete? Is there any defect over there, any problem over there? We understand that sulfonylurea secretes insulin. So glucose is suppressed. That's agreed.
Professor Sanmulya sir has specifically told there is a delayed response from the beta cell to secrete insulin.
Yes.
That is a very important. That is why 1 hour sugars made on high. That because of the delayed insulin response, the patient had a hypoglycemia postprandial.
Yes,
that is a
that is because of first phase insulin release is defective in type 2 diabetic, and that's the reason he is telling about.
Yes, absolutely, sir. So glucose sensing by the beta cell is there. When glucose rises, this beta cell senses the glucose and secrete insulin. But this is absent because of the NH1 F alpha.
HNF1 alpha is defective. So the sensing defect is there in all HNF alpha.
Absolutely.
HNF factor.
But whereas this sulfonylurea acts by blocking, closing the potassium channel. So different pathway. So that is the reason why
sulfonylurea helps in releasing the delayed sensing by the gene mutation.
This for understanding. This is understanding for you. Thank you.
I think.
Last question.
Yeah.
Sir, excellent discussion, sir. All the common and eccentric questions were discussed. Recently in our ICU, we had a case, sir. We had a 12-year-old female who was having recurrent decay. She was diagnosed as diabetic, type 1 diabetes, labeled somewhere. Then she presented to us. When we verified her and when we have undergone, we had the same situation where Modi, everything was negative. Then what we did, we referred to the genetic study for Ramachandra, and they have given the mutation as STNK11 gene. STNK11 gene, which only responded to the sulfonylurea. Only to the sulfonylurea it responded, and to the surprise, the patient did not have any seizures, and she was deprived of the insulin. STNK11 gene, sir. And now the patient is under the follow-up of JIPMER, and she is doing well. So, like this diabetic cases also we had. When we changed to Ramchandra for doing genetic study, we found out that, sir.
Good, thank you, Dr. Aditya. So,
the gene what you're talking is PPAR gamma mutation.
Yes, it is.
Then they respond to glucosomes better.
But it responded.
Sir, I'm telling you, see, this is a gene, PPAR gamma gene mutation.
Gamma gene is also there, sir.
Yeah.
So,
many
Gauri has the last slide. Gauri will.
So for lack of time, we will close the session. I think no doubt there was a fantastic discussion here. So thanks to all the panelists for joining us. Thank you all. Thank you one and all.